Where did we get to? We got to here, right? Yeah, we got to. So do you guys have any issues with respect to the project presentation or anything like that, or it's all straightforward? You're set, ready to go. All right, good. Um, so looking at ventricular and atrial function with CT is pretty clear that it's a you know straightforward and really cool application in that if you put contrast in the chambers, you get these beautiful borders of, so this is the left atrium up here. That's the left atrial appendage, that thing. This is the left atrium here contracting. This is the left ventricle. And what we're seeing, obviously, is the blood pool because we've injected this contrast agent and it's giving us this great contrast between the blood and everything else. So you get a 4D object, essentially. It's a 3D set of voxels. And then the fourth dimension is time. And so when you just play those back, you get these fantastic movies. So as you can imagine, we can estimate or, you know, essentially directly evaluate whether or not the heart is contracting normally. And this is review, if you recall, um, we have a volume, right, where you have an end diastolic volume of blood here, then the heart contracts. And the way it contracts usually is it gets shorter, right? So the valve plane here moves down this way. Let me turn on my laser pointer. Okay, so this valve plane, when the heart contracts, the valve plane itself will move down this way. So burp goes down. The apex of the heart usually stays roughly where it is in the chest, and the valve plane moves down. And so you can see between here and here that has occurred. This valve plane is down. The atrium fills with blood when the ventricle is emptying, right? So it's like they're out of phase. So I squeeze the blood out of the left ventricle and it fills into the left atrium. And so that amount of shortening occurs in that direction. And also the heart wall itself right here gets thicker, right? So we see the muscle, when it starts at this thickness and it goes to this thickness, right? So it just gets thicker. And that muscle contraction or muscle strain is the primary thing you want to evaluate when you're asking, is the heart contracting normally or is it in some abnormal state? Yeah. Oh, yeah, yeah. Sorry. Yeah. Yeah, no problem. I just forgot. Thanks. Okay. So you can measure, if you look at what we're going to see in that 4D that I just showed you, it will be this boundary, right? It's the boundary between the blood and the myocardium. And then at a later time, that boundary changes its conformation. It looks like this. And that's the thing that we're going to see in the 4D CT scans, right? This is just longitudinal shortening. The average amount of shortening is about 20% in a normal heart. Um, and then you can also measure very accurately with CT the volume, just the global volume of the left ventricle, for example, right? And that, if you plot it at each time frame, all you're doing, if this is the R to R interval over the heart, so there's a QRS complex here, we start scanning, the next QRS comes here. So this is in percent, 100% of the R to R interval between the two QRSs. And we can just count up the voxels that we have segmented as left ventricular chamber. Just count them up, and that gives you your volume of blood. And you plot it, it looks something like this, right? So This is myocardial shortening and ejection of the blood as the volume gets smaller. It stays in this configuration for about 50 milliseconds, something like that. It just gets to its smallest volume. And then in a normal heart, the muscle relaxes and it just pops open. The left ventricle pops open and sucks blood in from the left atrium. And it's a pretty sudden process. And this is where you get most of the motion artifact you're going to see in CT images, like when it's relaxing and popping open, all the vessels are moving around quickly. So not really a good time to try and image vessels sharply. Because once it's full of blood, it'll sit in that configuration in a relatively stable configuration, right? It's just slowly filling here. And then it fills at the end of the R to R interval. And the reason it gets this little kick is the left atrium contracts. And so that it's like a booster, right? The left atrium contracts and pops a little more blood into the left ventricle, and then off you go again to the next beat. So this very standard looking volume curve, you can get ejection fraction, etc. If you want to look at the local dynamics of a muscle or the heart, you need to have features that you can track, through space and time. And this picture is a human heart. This is the endocardium of the left ventricle of the human heart. And it was photographed optically. This is actually a video. So this video was taken with an oxygenated, clear, transparent fluid in the heart, right? So you inject this transparent fluid into the heart and you videotape while the fluid goes by. So now you don't have blood getting in your way, right? You can see what's going on. And all of these things, these are called trabeculi, and they're little pockets on the inside wall of the left ventricle. A very complex spatial, amalgam of tissues sort of on the endocardium. But what we can do in CT, which is pretty cool, is you can, let me take this off. You can image that structure, which is the sort of endocardial trabecular, indentations and everything. And you can watch those trabecular indentations change their conformation as you look in 4D, right? So you turn on the movie, and now you're looking at it. You can see the inside surface of the left ventricle contracting with some great detail, right? So that the proposal then would be, well, let's track features on the endocardial surface, and we'll use those features, the tracking of those features, to calculate whether or not the muscle is contracting or not. Another thing that's obvious here is this, see this feature up here? This little pocket of blood sticking out. That's the left atrial appendage. This is the left atrium here. And it is just that. It's a pocket that comes off the left atrium, and it fills with blood. And as you can see, it actively contracts and ejects the blood out of it. All right. So we're going to come back to look at that feature with CT, because that thing, if you get atrial fibrillation, that volume there is one of the places where thrombus can form, and you can throw a blood clot out of that thing and get have a stroke, right? So it's dangerous. Going back to the ventricle, here's the left ventricle in a, this is a 4D CT of a whole heart, obviously, but this piece down here is the left ventricle. This is the right ventricle over here. This is the right atrium, the left atrium, the aorta. So everybody's full of contrast during this single beat. We can see the right ventricle contracting. This is the surface of the right ventricle, pushing blood out this, which is the pulmonary artery. It's going towards the lungs. And then here's the left ventricle and the septum, but look at this thing here. That feature is just like this ball of tissue that's just being dragged around. It is not contracting, right? If you compare it with the tissue that's here, for instance, right? Right on the set. See how it's all contracting down together, but then this thing, you can just draw a very precise region around that and say that that piece of tissue is not contracting. It's just sitting there, right? It's getting dragged around, but it isn't itself actively contracting. And so it's trivial to like, you just paint a line around it and say, that's my abnormal spot, right? In the left ventricle. And what causes that abnormality is usually either a acute drop in blood flow to that region, or you had that acute drop in blood flow weeks ago and you killed the tissue and now the tissue is actually dead, right? And it's just a patch of dead tissue that's being transformed into a scar, right? So what we can do is we can like that. Look at the surface. This is the endocardial surface of the left ventricle, right? And we've got a super high resolution picture of that because we put this contrast in the heart. And now we're tracking those features. In this case, the yellow and red are the valleys of those features, and the bright blue are the peaks of those features. So when you look at it as a topographical map or a topological map, you have hillsides or the peaks that are up here, they're blue, and then the valleys are yellow. And you can evaluate that curvature locally and plot that curvature on there. And it's just a geometric way of saying, like, am I convex? Am I concave? Right? And those features now are the things that you can track to actually measure how much, compression is occurring in the muscle. And if there was an abnormality, you would see that these features would not move, they would just stay stationary. So what we do in CT, we have these displacement images, right? We can use your favorite tissue tracking or feature tracking software. So, in video, there's lots of software written to say, track the bikes in this field of view, right? And you'll see the output of that will be a box around a bike getting tracked across, right? The field of view. Or, track the airplanes in this field of view, and it'll track airplanes. So what we do, this is called, we use a chunk of software called coherent point drift. And it takes any old object like a chair, something like that in 3D, and it's a point cloud. And then at a later time, if that chair shrunk and rotated and moved over here, CPD will give you the displacement required to maximally match the points that you have. You don't have the same points in both views, but CPD will say, here's the displacement map you need to take your chair from here to here. And it's used in computer vision a lot. We use it to map, say, the beginning surface of the left ventricle to what that surface looks like at end systole. So I have one surface here as a complex object, and it's essentially represented by a cloud of points that have been segmented out on the surface of the left ventricle. And then at a later time, it's distorted, and we calculate what that displacement is to go from here to, say, here, which is end systole, and all the times in between, right? And then this spot on the myocardium, on the heart wall, the reason it's blue is because the surface had to get crushed down into a smaller space, right? So those points, in order to do the matching, had to crush together. And so that's, an indication that the heart is contracting in that point. At this point, you've got a yellow value here, which means it's actually stretched compared to what it was over here. At this time, it actually got stretched out. So it's supposed to be contracting between here and this time, but this blob of tissue is not contracting, it's getting stretched. So it's abnormal, right? The overview of that, we have a CT scan at some time at end diastole, say. we segment out all of the blood in the left ventricle. And this is now done with deep learning, right? The segmentation is done pretty fast. We recently segmented 500 patients, 20 time frames in one weekend, right? That would have taken 4 years, right, without the deep learning. Because we did a paper where we segmented 82 patients twice, so 160 times 20 time frames. And we split up all the labor amongst everyone in the lab so that we all took a shot at segmenting different parts. And it took us about a year to get to that data, right? So the paper's good paper, but it took a year of labor of a whole bunch of people in the lab to get the segmentation done. Say that again, I'm sorry. It was, well, not 100% by hand, but the guidance was by hand. It was done in a chunk of software called ITK Snap. And so you start with balls, and then they grow, and then you set a threshold for the gradient at which they'll stop. So the ball gets bigger and bigger inside the ventricle, and then it fills in all the corners, and then you stop it. And you look and go, that looks good. You cut it off at different surfaces and say, okay, now that's my left ventricle. And you do that 20 times for each patient, right? Because you have 20 times. Yeah, it was really, and people did it with different levels of skill, depending if they were motivated or not. And so we got variable results. And then when we went into training, so we used all that hand data to train the deep learning network, right? And then when we went into the training, we look for the dice scores of individual hearts that were poor, that indicated that the segmentation of the CNN had failed. And so we brought up all those cases, and when we looked at all those cases, 90% of those cases, it wasn't the segmentation of the CNN that had failed. It was the user, right? It was the manual user. We looked at them at the manual segmentation, said, nah, I believe the CNN more than I believe the ground truth, right? So now you have this interesting issue, like, well, so now do we just retrain and put the CNN segmentation in as the ground truth? Isn't that kind of circular? Don't you kind of wind down a place where you're just sort of training yourself on yourself kind of thing? So I'm interested if anybody has any thoughts on that. But that's how we're going at this point. And so now, yeah, as I said, like Lauren Severance in our lab has got this really nice pipeline going where, they did 500 cases at 20 time frames in a weekend. Like they started on Friday, it was done on Monday morning early or something. And when we zipped through them all, it looked like it got like 98% of it all right. So it's great. So all this now becomes viable, right? Because this step here, which had been an open problem since I started in medical imaging, which was in the 80s. Okay, people had all these ways to do segmentation and there's like 1,000 papers written on how to segment stuff. None of it works automatically. They all claim, oh, it's semi-automatic, it's this, it's that. None of it worked until recently with deep learning. Now it seems to be working. So it's a huge step, right? Now that all this automatic stuff will be done, it's a huge step. So we have a segmented point cloud here. So you segment out the whole left ventricle, and then you just pick the points that are on the surface, and you say, okay, that's my point cloud of surface points. And that point cloud changes. Like we segment this one at different time frames, and then coherent point drift will tell you what are the vectors, the displacement vectors that you need to employ to move this surface onto this surface, right? And then you take this vector field and you calculate how are the points coming together as a function of position, and you map that as a color, right? So here's my starting configuration. At some time later, everything's moved. This part of the tissue is contracting very well. Everything's coming together. This part of the tissue, it's getting stretched out because it's abnormal. It's not coming together, right? So we call this value here, we call it regional shortening with CT, just like the fractional linear shortening. This is what that regional shortening looks like as a function of position in the heart. So the base of the heart, the mid part of the heart, and then the apex of the heart is down here. And then this is as we go anterior, the septal region, inferior, then the free wall. So angular going around this way. And traditionally, if we think back to echo, remember we had 16 segments basically, and they were kind of mapped to the segments that corresponded to the flow in coronary arteries, different coronary arteries. So this is when you break up the map that looks like this into 16 segments, an average over each segment. This is what you get. And this is 25 people who didn't have coronary disease. They're normal. And they were scanned for what other reasons, right? So the mean looks like this. And then you can, if you have a patient, a single patient, and you want to ask the question, are they normal or not? You can compare their trajectory, right? And their amount of squeeze at each location in the heart to make that determination. So this person, they don't get as much squeeze done as a normal person. They're a little bit delayed, it seems, right? And they don't have, see how in a normal person, it comes back up and then sits at a constant position. So it opens up and then sits there for a while in diastasis. This person really doesn't have diastasis. They're just like up and down, up and down, up and down. So they're like a squeeze box just going like this. And that's classically heart failure. Yeah. In this, yeah. So this is, we just did this fit, calculated these curves in, I think, 28 different people. We just put them one on top of the other to demonstrate that it's pretty consistent how they look, right? These, there's some people will generate a lot more contraction because their cardiac output's higher or whatever. But in terms of timing and dynamic range and everything, it's pretty consistent. This is this is the mean of those 28 people, and the narrow line is one standard deviation away from the mean. So you can say, I now know what a normal heart looks like, right? And then when a patient comes along, you can compare them to that normal heart, right? And so in this patient, the principal thing that's going on is the shape of the curve is quite different in that it takes a lot longer to relax, takes longer to get down to its minimum. And so it's more like a sine wave than this underlying function, right? The other thing you have to take into account is that if you don't do motion correction in CT and you're using a scanner that has a single detector and it's going around every quarter second, right? So it's 4 times a second it goes around. You're still undersampling the motion field for some of the phases of the heart. And you can see this is classic artifact here in that the heart seems to take discrete steps in. So you really have to go back and do motion correction frame by frame, which is absolutely possible because you can detect all these surfaces and do motion correction. Okay. So that's cardiac function. My feeling is that when I compare MR cardiac function, echo, and heavens, nuclear medicine cardiac function, remember what it looked like? It looked like a blurry donut that was just sort of going like this, right? You don't really have any details about what's going on there. But CT, you can draw a very precise line around a region that has low function, right? So for me, it's the go-to technique if you're going to do cardiac function because The other thing is you get all of your data in one heartbeat. In MR, as we'll see, it takes 16 heartbeats to get a good movie, something like that. So this is way more robust. I just need one beat, right, to get it. So then another application is looking at patients who are in atrial fibrillation. This is a very common malady, especially in people who are over 65. And their left atrium, which is classically you have a set of cells in your atrium that are like the pacing cells of your heart, and they depolarize at a very regular interval. And then there's a coherent wave of depolarization that goes out over the left atrium, goes through it's called a His bundle into the ventricle, and then that depolarization goes around the ventricle, and it happens in a very uniform, reproducible way. In atrial fibrillation, what happens is you get a pulsing from those cells. However, what happens is there'll be a wave of depolarization that'll go around the atrium. It'll curl back on itself and re-depolarize itself, and it will never stop. So it doesn't just go depolarize, relax, repolarize, depolarize, relax, repolarize. It goes zoom, zoom. It's always depolarizing in some kind of loop. It's like a cat chasing its tail, right? And then it becomes random. And so the left atrium just sits there. It doesn't really contract in a coherent way. And it also doesn't control the heart rate in a coherent way. So the left ventricle and the right ventricle are kind of left to their own devices. They will pace themselves eventually. If you don't give them a pacing signal, they'll fire and pace themselves, but usually much more slowly than if you fire from the atrium. So atrial fibrillation, there's about 1 million people in the US who are in atrial fibrillation right now, right? And the way you know you're in atrial fibrillation is like when you take your pulse, it's very irregular from one pulse to the next. So it's like a random number generator, like in terms of the interval between each pulse, right? And that tells you that patient's in atrial fibrillation. The main risk with being in atrial fibrillation, other than the discomfort, because you kind of feel it, like when you skip a beat, if you've ever been just relaxing and then your heart like does 3 quick beats, or it doesn't beat for a while or something like that, you can feel it. When you're in AFib, it's like that all the time, right? So people like have difficulty walking up the stairs, doing things like that. They just feel uncomfortable, right? So you really want to get out of AFib for the discomfort, but principally the real risk is if you don't get a really nice atrial contraction, the blood can stay in the same location for a long time. And when that happens, it can clot, okay? So if you take a test tube of blood and you just take it out of your vein and you keep shaking it, it won't coagulate, right? Because you just keep mixing it. It takes a lot longer to coagulate. If you just leave it static, then there's a biochemical process that just turns on and you start making coagulated blood, right? And it's just stop bleeding and things like that. So in these patients that are in atrial fibrillation, their atrium is not moving the blood around very well. And so it pools. It has a high probability of coagulating. And when you get coagulated blood in the left atrium, this is a terrible thing, right? Because it can go down into the left ventricle, this clot, and then right out of the left ventricle, it's going to go up your aorta. The clot travels up your aorta, and then you've got 2 large arteries that go on either side of your neck, your carotids. It'll go up those, right? And then it'll go into your brain. And then it'll lodge somewhere in your brain and you'll have a stroke. So that's a classic way that people have strokes who are in atrial fibrillation, right? So one of the open questions is, all these people in atrial fibrillation, should we give everybody a drug that keeps their blood from clotting? right? So you can give somebody a drug. There are many drugs that do this, such that it's really hard to make your blood clot, right? The problem with doing that is if they're 65 and they fall down the stairs or they bump their head or something like that, then the natural process of closing that injury isn't there and they get a bleed, right? So they can get gastrointestinal bleeding, they can get bleeding in their brain, God forbid, right? So you don't want to put everybody on that drug. You just like to put the people who really need the drug, right? So that's a long build up to this problem, but cardiac imaging is a big deal in this problem, right? With echo, can we see the left atrial appendage with echo to see if the blood flow is okay in there? MR has been used for it, and I believe CT again can be the imaging method that is preferred for this. So looking at both left atrial and left atrial appendage function with CT is what we'll look at. And let me just show you quickly what it looks like before I go back to this. So this is the left atrium, right? These four big vessels that are coming into it are coming from the lungs. So your right heart pushes the blood to your lungs, it gets oxygenated, and then all these small vessels gather up into four big vessels that come back to the heart from the lungs. And as you can see, this is uncontrasted blood coming in there into the left atrium. The left atrium, right before the left ventricle contracts, itself contracts coherently and pushes that booster shot of blood into the left ventricle. And this is a normal left atrial contraction. So you can see the roof here pushing down as the left atrium is contracting. You can see also here the pinching in here, like, so that all looks good. Then on this side, that previous one, we were looking from over here. We were behind the patient looking this way at their left atrium. Now we're looking through the patient's chest towards the front. So this is the front of the left atrium here. And it turns out that is principally where most of the contraction occurs in the front part of the left atrium. Actually, one of the students from this course did this as their project last year and has turned it into their master's thesis project. We now have, he's the guy who goes to 500 patients, right? So he's measuring left atrial function in all these 500 people before they go for an atrial ablation to try and predict whether or not they're going to respond to that ablation. But the interesting thing in this movie is this is the left atrial appendage. So it's a weird looking little pocket, right? It's got all of these little rivulets going down into a distal complex structure, right? In this patient, they're not in atrial fibrillation. That motion, that contraction there shows that they have coherent atrial contractions. So they're not in atrial fibrillation. They're not at high risk. The blood, at least 50% of that blood, if not more, maybe 75% is getting squished out of that left atrial appendage each heartbeat, right? So there's a lot of exchange of blood there. It's probably not a high risk situation. A person in AFib, I don't know if I have a movie, basically their atrium doesn't move. It inflates when the left ventricle contracts and then it relaxes back down, but it doesn't do that power stroke, right? And we'll show you some. The other thing that you can do for these patients is if you're concerned about giving them these anticoagulants, or you're concerned that even if you give them the anticoagulants, their atrial fibrillation is so bad that even with the drug, they have a chance of getting a clot, then you can use what's called a closure device. And this is a little plug. This thing is it's a bigger diameter than a quarter, and it has a mesh over top of it. And what you do is you take this plug on the end of a wire and you put it right at the mouth here of the left atrial appendage that looks, this is from CT, and you plug it into right here, and then you essentially shut it off. It's like a door. And then it endothelializes, and so the blood that's trapped inside the left atrial appendage cannot come back out, right? The alternative thing is you could just surgically go in here and cut this off right here and sew it up so that now you have a stump. You don't have a left atrial appendage where the blood goes down, sits for a while before it comes back out, right? And that's surgical removal of the left atrial appendage. It's often done when you're doing some other kind of surgery anyway. The surgeon will say, you know what, I'm just going to take this thing out because it does you no good and it's just risk. And so those are the options you have. Put them on drugs, put one of these closure devices in, or surgically close off the left atrial appendage. Those last two are pretty expensive, complex procedures, right? So you want to be sure you're putting it in the right person. So this is a interesting, remember we're going back maybe 2 lectures now, where we're going to take a CT image with low dose. So this is why the images look so grainy, but we're going to take a set of images as we inject the contrast agent to see how the contrast agent moves from one chamber to the next in the heart. So when you inject it into the patient's vein, obviously the right side of their heart lights up first because it comes into their right atrium and then into their right ventricle first. And then after that, it goes off to the lungs and comes back to the left atrium, which is this thing here. And I've cut this such that we can see the left atrial appendage, or at least one slice through the left atrial appendage for all of these views. There's 27 time frames here, and we're playing it back as a movie. And you can see that there is a delay in how this lights up at the distal end, right? So it takes longer to light up, and it takes longer to drain out, right? So this patient, if we look at this purple slice here, is a plane that's perpendicular to this one, showing their whole cross-section of their left atrial appendage through a slice where we're getting a lot of the left atrial appendage. And you can see that it lights up quickly in the proximal part of the left atrial appendage. There it lights up, and then there's a long delay before the blood gets to the distal part of the left atrial appendage. So this is, now you have the ability to look at the dynamics of the blood flowing into the left atrial appendage and out, right? By just using simple CT scanning. There's nothing super complicated about this. It's just that you turn the MA way down. So it's like 50 MA or 100 MA, something like that. And you take multiple pictures gated to the heart, right? So we take them such that for each picture, we're in end systole here. And so the heart looks like a constant picture. Now, the one tricky bit of this is that obviously, if this is 27 images, it takes like 38 seconds or something for this to happen. The patient can't hold their breath. This picture has been corrected by geometrically deforming the picture such that it sits on top of a template picture. So every picture looks the same in space, right? So that's a step that luckily that software had been written. We didn't have to write it. But you can plot the intensity. So here's time, right? And this is in seconds. So this is a long time. And each one of these dots is a CT image, right? And what I've done is this blue dot here is the signal in the left atrium as a function of time. So if I put my cursor here and measure brightness for each pixel, right? Or each region of interest. So I put a circle there and I just measure what's the mean signal as a function of time. It's obviously going to go up and then go down, as you can see from the picture, right? So this is the left atrium here. And then with a short delay, we get almost exactly the same enhancement and then drainage of the left atrial appendage, but right at the proximal part, right where the left atrial appendage comes off the left atrium, which is, I'll show you where that is, say right here, right? So this whole thing here, let's put this back. This whole structure is the left atrial appendage. This we're calling the proximal part. And when I plot that, I get virtually the same curve as I got in the left atrium, except it's just delayed in time a bit, right? But then as I go farther down into, you know, the distal area, so this area here, as I go farther down, I get a later enhancement. The peak happens later, and the peak doesn't get as high, right? So basically, it peaks late, and it peaks at about half of what it was in the left atrium, and this peaks very late and peaks, you know, at about a third. So you can use these data to quantitatively estimate whether or not this person has risky flow in their left atrial appendage, right? That's the idea, right? And so you can, using those pictures, just measure some simple things like here, this is the left atrial appendage, this sort of triangular thing here. And this is in seconds. When does the signal at a specific voxel lift off the baseline and start, you know, and it's like 10% towards its maximum. And so these are delays. So you can see here's 15-second delay. This is like 9 seconds back here. And in the left atrium, which is down here, you're down at about 6 seconds. So 6, 9, 15 seconds are those delays. And looking at when that signal at that voxel hits its peak, you can make a plot of that as well. So here we see the peak is way out at 30 something down here, 30 seconds, whereas here it's at 17 seconds, right? So all of these relative dynamics can be examined. And here is a map of time to peak in another patient where if we look at the time to peak in the left atrium, which is this, we get, say, 20 seconds. And then as we move up into the left atrial appendage, we see longer and longer delays up here. So this person, you can't deny that the blood is taking a long time to get in there and it's spending longer in there, right? So the flow is abnormal in this person's left atrial appendage. When you do this, we've been doing this now for 2.5 years or something, maybe 2 years. And this is 75 patients most of whom are in atrial fibrillation and most of whom are going to therapy to try and get the atrial fibrillation to stop through ablation, which we won't discuss, but it's a method to try and stop the atrial fibrillation. And what's plotted on these axes is this is the time to peak for the distal part of the left atrial appendage. So, you know, this is 5 seconds, 10 seconds, 15 seconds. So there's a set of patients here who have fairly extended, if we cut it here, greater than 10-second delay for that blood to get down to their left atrial appendage distal portion. Whereas the vast majority of people are all clustered here. So their left atrial appendage, even at its distal part, lights up within 2 seconds of the left atrium lighting up. So those folks, you have to look at them and say, they probably don't need any special consideration because the flow's going in and coming out just like that. They're almost normal, right? However, when you look at the folks, this group blown up here, most of those people are in atrial fibrillation, right? Which is kind of weird. Their left atrium is not contracting aggressively, and yet the blood gets into the appendage and out really quickly. So just by looking at the function itself, you don't know what the flow is going to look like, because these folks down here who are also in atrial fibrillation have dramatic delays in their filling and obviously the attenuation here. So this is the kind of graph you would use to say, you know what, I'm going to cut this graph here. Everybody on this side down here is at high risk, and they should all go and get a Watchman. They should get this thing, that, right? So you want to cut their left atrial appendage off because it's placing them at high risk of having a stroke. And so that data, I believe, would support that, right? So that's using CT to get this dynamics, these blood flow dynamics, to make a clinical decision, right? Any questions about that? So this scan, I mean, the tricky bit about this scan is you have to take multiple pictures, right, with low dose. And so the question is, how many pictures do you actually need to take in order to classify a person as a high-risk person versus one of these lower-risk people? Yeah?
In this case, the sinus just being non-native.
Correct. Right. Sinus is, it's the sinus rhythm. And we had some patients were in what's called paroxysmal atrial fibrillation, which means they come in and out of AFib sort of randomly. And when we scanned them, when we looked at the EKG, when we were doing the scan, it was pretty clear they weren't in AFib when we did the scan. And when we look at the movie, because, right, we do say 27 images, but the 15th image right in the middle of all this, when all of the contrast is its brightest, we image the whole heart cycle and we play a movie of their heart. And you can see whether or not their atrium is contracting, right? And so that confirms that they're in sinus if they have this contraction. And so nobody who is in sinus wound up down in this group. So if you're in sinus, you probably you shouldn't worry because you're not going to wind up down in this, at least according to our statistics thus far, right? We haven't seen one down there. However, if you're in AFib, you can be down here or you can be in here. Like most of these people in here are in AFib. And yet it still flows in and flows out. And so the question there is, do you actually need to give them a blood thinner if they're up there? Maybe to be on the safe side, if they're in AFib anyway. But you have to be concerned about these patients, even if you give them a blood thinner, right? Because there's so much of a delay and so much of a pooling that maybe they still throw a clot, even if you've got this blood thinner on board. So that's the advantage of taking courses in a place where you do active research, because that hasn't been published yet. So you guys are like the 10th, 11th, and 12th person to understand that data, right? So it's a great project, though. It's really cool. So the other thing CT is used clinically for a lot is planning interventions where you need to know the structural shape of the heart. And one of those things is TAVR, or it's sometimes called TAVI. And it's the transcatheter aortic valve replacement. And the cool thing about this is you have a catheter that goes in the patient's femoral artery, down in their groin. And on that catheter, you've crushed down a valve, an aortic valve, right? A mechanical aortic valve, such that it's a very thin cylindrical shape. And then you push that up their aorta and bring it around and push it through the existing aortic valve, which is right here. Just push it right through and then blow it up and deploy it right in place. So you put a new artificial valve in this person without cracking their chest. So SAVR is surgical valve replacement, which has been very successful and has done a lot of people. If you have a terrible aortic valve, you have to do something, right? And so they crack their chest, cut open the bottom of their aortic root, and then plug a mechanical valve in there. or it's oftentimes a valve that's made of animal tissue, like a porcine valve or something like that. And you just stick it in place, right? Sew it in. And then once it's in, all your, you either, there's a couple of things that can happen. We think back to the beginning of the course, we looked at what can happen to valves, and they can get stuck closed such that there's a tiny little hole and your heart is really pushing hard to push it through a tiny little hole, or the basically the leaflets of the valve can break and the thing's flapping open all the time. So basically you squirt blood out, but then when you relax, blood comes straight back down in, right? For down the aorta. And so both those conditions are not good. Older people often get valves that look like this. It's got calcified, crusty stuff on it, so it can't really open that well. So these are like people in their 60s and 70s, 80s, right? So they need a new valve. CT is phenomenal for planning how this is going to go because you have different size valve devices depending on the size of the person, right? And so you want to know what is the size across here of this person's valve. This is where the coronary artery is coming off. Where does that come off? I don't want to open the valve such that it closes off the coronary artery, right? So I have a valve device, blow it up, and if I lock the coronary artery closed, well, that's not a good plan, right? So we need to move the valve down so that it doesn't block the coronary artery. So you get that height to the coronary artery here. And now you know what is the geometrical location that I have to stick a valve in. What size valve should I take off the shelf to do that? And then they put it in under X-ray fluoroscopic guidance. And usually they'll have echo in there as well, right, in the lab. But the CT is always available to take a look. Oh, this is a cool this is like homemade interventional planning, or we're calling an audible in this patient. So this patient had a surgical aortic valve put into their heart, right, for their aorta. However, the surgical valve didn't work that well. There's a big gap on one side, big gap on this side. And if you look at the top of the valve, you can see all of this space around it. So it makes the blood is going, around the valve, right? So it basically came off of its mount. And so there's a big hole here where blood is going. And we can measure that with CT very clearly, right? It's hard to see all of that geometry on fluoro, et cetera. And so what these interventional people can do is they can put these plugs on either side of this to try and close it up so that the valve is perfectly fine. It's just a lot of blood is going around the valve. So you just need to close this up. So what we did was we took these CT images, right, and we 3D printed this geometry here with the valve in it, right? And so here you can see how there's a huge gap here around this valve, big gap over there. And so we 3D printed that geometry. And then when you look down through the aorta here, here's the coronary artery coming out. Look down through the aorta, you can see where the valve is. And here's the ring of the valve here, right? And this is the gap that is required to be filled. And so this is the interventional cardiologist who needs to fill that gap by putting these plugs in there. And they come in all different sizes, right? And so what we did was this is the rep, the company rep that makes these plugs. And he has this whole suitcase full of different sizes. And so what the cardiologist did was he took each one out and then planned how he was going to plug that gap up because he could do it with the right geometry, right? And the other interesting thing about 3D printing and doing medicine with 3D printing is that it's real. You can see it's all to scale. Everything's the right size and everything. So you see how it's going to go. But also this guy here is like the chief of cardiology. He's the big boss guy. His name's Shami Mahmood. And so he's got a ton of experience, right, interventionally. And when we're doing this, to get this guy to come to your lab and then display how everything's going to go on a computer, like, oh, this is what we're going to do. We're going to do this. It's never going to happen because he's so busy, right? So what we do is like we walked with the 3D model to the clinic where he's seeing patients and just waited outside a door, right? We knew he was in with a patient because we saw his schedule. And he comes out the door and we go, hey, Shami, do you think this is going to work? And he just put it in his hand and here he is. And I took a picture and he's looking and he goes, oh, this is this size, this size. Yeah, that'll work. And walks away. Right. So that was the meeting, right? You know, to get that to happen. And otherwise, like, so that's the advantage of having it in your hand that you can just take it, right? As opposed to having him come to some computer space to try and show what's going to happen. So that was pretty successful. That they did that. The guy's fine. Like the patient, that was like 2 years ago, no, 18, even more, and the patient's still doing great. So here's a few more things from CT, and the reason that, oops, sorry, I'm showing you these is this is a left ventricular assist device, which is a big complicated pump that you put in the heart. So here it is in a patient. It's got a pacing lead here. It's got a pump here. You plug it into the apex of the heart here and the return there. And you can't image that thing in MRI. It's just not going to happen, right? And when you're trying to image it with echo, obviously like the echo doesn't go through the parts of this thing, right? So it's just like full of artifact. However, on CT, you get really nice pictures and really good movies of this thing going, right? So that's the other advantage of CT, not just for myocardial function and all that stuff, but if you have a complex case where the patient has a lot of mechanical gear there, then CT is the way to go because you can just look right through it, right? And then you can like take an image of the mechanical gear and where it is and things like that. So it's a good technique that way too. Okay, thus ends our discussion of CT applications in cardiac. Those are pretty deep about specific problems, right? And the thing we touched on and looked at was, which is probably the most common use of CT in the heart, is imaging coronary arteries, right? Because that's like the, you know, gold standard diagnostic thing you want to know is, does this person have a really bad lesion in their coronary artery? And so that, if you think back to those pictures, those are really important, right? And people who come in with chest pain to the hospital, in my book, it's my mom or my dad or something like that, and they've got this chest pain. First thing you do is a CT, and you see, is this actually from coronary disease, right? And in 50% of people, it is not, and their vessels open and everything, and you just go a different pathway. You don't have to sit there and work them up and then go to the cath lab. So that's the main application. Okay. Any questions about CT? I think we're pretty done with CT. Yeah.
Like something about was the valve,
Yeah.
but the blood, but like the worst case, your stand or your valve is broken.
Yes.
How do you like remove it, take it out of the heart?
That's a really good question. So the question is, if you have a device in there and is broken, how do you get it out? And the worst, case scenario is you can't pull it out with any kind of catheter-based device. You basically just have to cut the patient open and pull it out, right? Yeah. So you essentially, if it's surgically, you can get anything out surgically, right? Now, sometimes you are able to, and this happens it's not common, but you can do this. If the device itself fails for whatever reason, you can put another device inside it. So let's say it's a big stent in your aorta, and for whatever reason that stent, one of the tines or something failed or broke or has some kind of mechanical problem, you just put another stent inside that one and open it up, right? And that's possible to do that. Or you've deployed a stent in a coronary vessel and you didn't go far enough. And for whatever reason, like the stent ends, but then there's still more, you know, basically vessel behind it that has a lesion on it. You just put another stent inside that first one, and then you continue to open it up. So you can gang them together and things like that. So, and then interventionalists are very creative, right, at how they get around these problems. So, you know, they they're sort of engineers slash uh, drivers of these things, and they just figure it out. And then it's just you can't do anything; you have to do it surgically. So, in a lot of places, say when you were first doing TAVR valves, you needed surgical backup that was ready to go. So basically, those guys were on call while you were doing the procedure, such that if everything went wrong, you just roll the patient down to surgery. Just do it that way, right? Now, with all this huge amount of experience, that's not required anymore. You don't have surgical backup on ready to go, you know. So because it's so rare that a major problem like that happens. But 20 years ago, when they first started doing it, it was pretty scary. Yeah. Okay. All right. So what we're going to do now is we're going to look at MR physics. Well, first we'll review MR cardiac briefly. Let's see what time we at. We stop it at 10:50, right? So we got 15 minutes. Okay. Um, so this is, idealized what it looks like when you're going to scan somebody's heart with magnetic resonance. And as you guys know, there's this static magnetic field provided by superconducting coils in this thing here. Do you guys know this? Have you guys taken MRI? You have, but yeah. Are you familiar with MRI at all or not? It's fine not to be. You did, right? Right. Okay, yeah. Okay, so we can just quickly go through this then. So, the superconducting coils are in here. You've got them in liquid nitrogen. It's a little bit expensive. Some of them have actually liquid helium on the inside to get down to 3 degrees, etc. So it becomes more expensive. Normally you have EKG leads. This is somewhat idealized, and the patient doesn't have any EKG leads, but you have a radio frequency coil that is custom designed to essentially illuminate or receive signal from the chest all the way down into the heart, and then you roll a person into the middle of the scanner here. Normally, you'll have some third-party device that gives you a nice EKG. And then there's also this thing over here, which is a contrast injector, just like the same contrast injector in CT, usually the same company. And that's for MR contrast. And MR contrast in cardiac is used a lot because when you see the tissue light up in MR, like during a dynamic injection, it's pretty impressive. This is where MR, I think, kills CT and echo and everything else, is when you inject a contrast agent and you dynamically watch the heart and the myocardium change its signal in MR. It is very impressive, right? Functionally, you can take pictures at different times in the R to R interval. So you take the QRS and you gate your MR scanning and you collect your data such that it's temporally aligned, say over 16 heartbeats, and then you play back, say 16 frames, and you get a movie like this. And it's pretty spectacular, right? I mean, the brightness of the blood is due to the inflow of blood into the scanning plane, so it gives you a really high signal. The myocardium here, you can see a really gorgeous estimate of the amount of radial thickening that's occurring when the heart's contracting. And so, you look at this, there's no comparison with this, say, to echo. This is so much better than echo, right? Just in terms of the details that you see and the function and everything. The time resolution is lower, and the patient had to hold their breath for, say, 12 beats, something like that, 12 to 16 heartbeats in order to get quality data like this. So that's why this is their diaphragm. If they were breathing, this would be moving up and down this way pretty aggressively, right? So they're holding their breath for this acquisition. So look at, this is fat. Along here, the bright stuff is fat. This is fat, all this bright stuff. Interstitial fat here, this is fat. This is their liver, right? These are lit up because the blood is flowing into the slice from outside the slice. So it basically, the magnetization, you get the full-on magnetization each acquisition. These are vessels down here, like surface vessels. That's a vessel up there. This is a layer of fat in this groove here. And you can see the lumen of the coronary artery there. Right? What we've done here is just change the gradients such that the imaging slice has changed its angle, right? And basically you can figure out a set of scout images to take such that you just draw a line on one of those scout images, and that is the imaging plane you want, right? So you can have 3D scouts. And so this is, this is called a four-chamber view for obvious reasons. You have the right ventricle here, the left ventricle, this is the left atrium, and this is the right atrium. Again, that is a coronary vessel. That's the right coronary vessel running around the back. You have that big thing right there. The big circular thing is the cardiac vein. It's the great cardiac vein, which is a really large diameter vessel. And then beside it is the coronary artery. You see really nice depiction of the valves and how they coapt nicely. And then when they open, they sort of rock back and forth. So you get that dynamics. Again, you get myocardial thickening, really well sampled here. Sometimes it's a little confusing in that if you're not right in the middle of the heart, say this slice was off to one side a little bit, then this thickening would look artificially high because it's basically a 3D object that's moving into the plane, and it looks like it's thickening, but it's just that more heart wall moved into the plane, right? So you want to do things in 3D if you can. One thing that's really cool about this movie is see how there's a obvious circulatory motion of the blood as it comes through there. The reason it has a different signal is because the blood that's outside the plane doesn't get excited or doesn't give off signal because it's not on resonance. But then when it moves into the plane, it gets an RF pulse and gives off a lot of signal, right? So it's not in steady state. It gives off a lot of signal. That's why it's so bright. And the really interesting thing is if this circulatory motion, this swirling motion, was not reproducible, if it wasn't exactly the same for the 16 heartbeats that were used to make this movie, the signal would not be encodable because it's not reproducible from one beat to the next. And what it would look like is just a vertical hash of signal up and down because it couldn't be phase encoded, right? Because the amount of phase depends on the velocity. And what would happen is this whole thing would just wind up as a streak up and down here. It doesn't. Therefore, that flow that you see there is reproducible beat to beat by definition, right? Otherwise, we couldn't image it, right? Which is kind of cool, right? That it looks kind of like it would be random, but it's obviously not random, right? Same with the flow up here, right? So MR, it turns out, is a very good method for measuring the actual velocity field of virtually anything that has velocities of reasonable numbers, right? And we'll take a look at that. This is the two-chamber view. So again, left atrium is here. You can see the contraction. See that buff, that quick contraction there? That's left atrial contraction. Or the P wave on the QRS curve, the right before the QRS is a P wave, and that's the depolarization of the left atrium. And we're seeing that happen here. See how it squeezes in quickly and gives a little boost here. Again, this is the great cardiac vein. This is fat on either side of it. That is the aorta. And what's interesting here is you can see that there's also a circular flow, like a vortex of flow. And when the blood goes into the aorta and it makes the turn, there's this constant vortex of flow as it goes around there. What else is interesting here? Oh, there's blood flow in the vessels in the lung field. Here's some very bright vessels. And all of this white signal here is interstitial fat, right? And this stuff here. So this is a classic short axis view with MRI where, it's the classic donut of the short axis of every other technique we've looked at. When the heart is as full as it's going to get of blood, and then this is as empty as it's going to get, so it's end systole. And what you can do with MR, which is different than, say, echo and other things, is you can mark the tissue before at a specific point in the cardiac cycle. So at the QRS, when you detect the QRS, you can inject a set of radio frequency pulses and gradient pulses that essentially cause a nulling of signal in parallel planes. So it's like putting the patient in a chopper, cha-chunk, and putting these parallel slices of signal that are dark lines, right? Or they're dark planes. And so when we image orthogonal to those dark planes, we see them as dark lines in the picture. The really cool thing is, if this is what they look like at end diastole, just after we put those dark lines in there, then 300 milliseconds later, here, when the tissue moves, you can see how the lines have actually moved, right? So this is pretty unique for MR. We don't have, in any other imaging modality, a way to actually mark the tissue and then watch the motion of those marks. So this is called myocardial tagging. And so these lines are called tags. And then you track the myocardial tags in order to measure the function in this heart. So if we go back and look at here, we start with a separation between these tags of, let's say, 7 millimeters or something like that. And then at a later time, you can measure the separation, and it's now, 4.9 millimeters. And so, at this tiny portion of the heart right there, if I measure that distance really accurately, I now know exactly how much it contracted down, right, at that location. So I would say it is the default gold standard for measuring myocardial strain is this type of analysis. Because it's hard to see how it goes wrong, right? If you have here, this is muscle in the chest wall, starts out with 8 millimeter separation. And then at this time, it's still 8 millimeter separation, right? So there's no strain there, it just didn't move. Whereas in the heart, you see this variant, it starts out with this straight line, and then it becomes this, curved line. So that you can measure very precisely what myocardial function is with MRI locally in different parts of the myocardium. Right. And here you can take it to an absurd extreme in a experimental lab. This is like a porcine animal experiment where we have gated to the QRS of the animal, plus we've gated to the respiratory cycle so that you can average data over many, many heartbeats, let's say over 128 heartbeats, right? So in order to get high signal to noise in MR, you have to average data together because the signal to noise in MR goes as the square root of the scan time you take to acquire your data. And, you know, you get this ridiculously high spatial resolution map of myocardial strain, right? And to do this in humans would be very hard because you would need to have them essentially breathe very regularly, and you would need to gate on their breathing as well as their EKG in order to get resolution like this. I'm not saying it can't be done, but it would take some special effort, right? But in looking at, you know, myocardial strain and experimental technique, this is obviously a ridiculously good standard, right, for measuring strain. So we'll stop there. Yeah, question. Yes, RF excitation and gradient. So it's like if I was to excite parallel slices down here, right? That's what's happening. It turns out the way you do this efficiently is you do one RF excitation, say on the whole field of view. You then put a phase shift across that field of view with one gradient, and then you hit it with another RF pulse, and then depending on the phase of the magnetization in the plane, the RF pulse will either produce, you know, it'll take the magnetization to minus Z, and then when you go to image, you just won't get signal, right? So that's sort of how it's done. Okay. We can look at, there's more complex, you can make all kinds of patterns, right? But it's RF excitation with gradients. Okay, let's stop there. We'll take up more MR stuff on Wednesday.